Thank you for the great opportunity to present our recent findings from the DOPS. What I'd like to show you today is the relations among secondary hyperparathyroidism, weight loss, and mortality. These are my disclosures. So wasting is a common complication of kidney failure that leads to weight loss and poor outcomes. The key characteristic of wasting is elevated basal energy expenditure. A previous clinical study reported that patients with secondary hyperparathyroidism have increased energy expenditure, and this condition could be reversed by surgical parathyroidectomy. However, the precise mechanisms underlying these observations have been unknown. Recently, we and our collaborators found that PTH plays a key role in wasting. In an animal model of kidney failure, elevated PTH acts on adipocytes through the PTH receptor and triggers adipose tissue browning. This leads to increased energy expenditure and weight loss. Similar findings were obtained in cancer model, where PTH-RP plays a role in the cachexia. So the purpose of this study was to test the hypothesis that secondary hyperparathyroidism leads to weight loss in hemodialysis patients, and this pathway in part mediates the association of secondary hyperparathyroidism with mortality. To do this, we analyzed data from the DOPS, an international prospective cohort study of hemodialysis patients. We included over 42,000 patients from the DOPS phases 2 to 6 collected between 2002 and 2018. The exposure was baseline PTH levels, and the outcomes were percent weight change over 12 months and mortality. We used linear mixed effect models to estimate the association between baseline PTH and percent weight change over 12 months, adjusting for country, demographics, comorbidities, and laboratory values. And we used accelerated failure time models to assess 12 months weight loss as a mediator between baseline high PTH and mortality after 12 months. This slide shows the baseline characteristics by PTH categories. Patients with higher PTH tended to be younger, have higher body weight, fewer comorbidities, and higher serum phosphorus levels, and be more often prescribed active vitamin D and cinacalcet. The degree of appetite loss was comparable across categories of PTH in available samples. This slide shows the distribution of percent weight change during 12 months by baseline PTH level. The proportion of patients who lost more than 5% weight was increased with higher PTH levels. Likewise, on average, patients with higher PTH had more weight loss. This slide shows the association between PTH levels and weight loss in multivariable models. After adjustment for covariates in Model 1, higher PTH levels were associated with more weight loss, and the results were consistent across different models. As the association between PTH and percent weight change may differ geographically, we performed a stratified analysis by region. The association between PTH and percent weight change was most dramatic in North America. By contrast, the association was less pronounced in Japan, where there was almost no association among patients with PTH levels higher than 300. Because the target PTH range is between 60 and 240 in Japan, patients with elevated PTH levels would be likely to receive therapy to lower PTH more quickly, which might attenuate the association between high PTH and weight loss over subsequent months. Next, because hospitalization may lead to marked weight loss, we separately examine the association between PTH and weight loss over 12 months among patients who were and were not hospitalized during this period. As expected, the mean percent weight loss was larger in patients who were hospitalized during 12 months. However, PTH was associated with percent weight change regardless of whether patients were hospitalized or not. We also performed stratified analysis by lack of appetite in available samples. While patients with poor appetite showed larger percent weight changes, high PTH was associated with weight loss only in persons who endorsed preserved appetite. It is known that patients with poor appetite have multiple factors that lead to weight loss, which might obscure the effect of PTH to induce adipose tissue browning. Finally, we examined whether weight loss mediates the association between high PTH and mortality. The model estimated that patients with PTH levels over 600 had 11% shorter lifespan, and 18% of this effect was mediated through weight loss larger than 2.5%. When we tested 4-month weight changes as a mediator between PTH and mortality, patients with PTH levels over 600 had 15% shorter lifespan, and 3% of this effect was mediated through weight loss. When we modeled percent weight change during 8 months, patients with PTH levels over 600 had 14% shorter lifespan, and 11% of this effect was mediated through weight loss. These findings suggest that weight loss due to high PTH is gradual, and the indirect effect of PTH on mortality mediated through weight loss accumulates over time. So, in summary, in the international DOPS cohort of over 42,000 hemodialysis patients, elevated PTH was associated with subsequent weight loss. This relationship was sustained after adjustment for numerous covariates, robust regardless of whether patients were hospitalized or not, and more pronounced in persons with preserved appetite. The association between PTH and weight loss partly mediated the higher risk of mortality associated with elevated PTH levels. In conclusions, our findings indicate secondary hyperparathyroidism may be a novel mechanism of wasting in dialysis patients, corroborating experimental data, and this pathway may be a mediator between elevated PTH levels and mortality. Future research should determine whether PTH lowering therapy can limit or prevent weight loss and improve longer-term dialysis outcomes. Thank you for your attention.